Hi, I'm Jed Henneberry, Director of Marketing and Member Relations for ABMP. I hope you're enjoying the ABMP Head and Neck Summit, and I'm excited to introduce our next presenter, Douglas Nelson. Doug started practicing in 1977, and he still maintains an active practice today. As president of Bodywork Associates, he teaches 100 trainings or so annually in precision neuromuscular therapy. He's a consultant for the NBA and the NFL. He's just a really, really amazing guy. I had the pleasure of reading Doug's columns in Massage and Bodywork magazine for many years as an editor, and I was always really impressed by how his clients would come in with problems and they'd leave with solutions. And I think he's going to do the same for you today in this presentation. He's going to talk about the big three muscles that could limit cervical rotation. He's going to show you assessment methods, explain specific anatomy and function, and then demonstrate some treatment options and hands-on work that you can use in your practice. I hope you're enjoying the ABMP Head and Neck Summit, and I know you'll enjoy this next presentation from Douglas Nelson.
Hi everyone, this is Doug Nelson, and I'm really excited to be part of this webinar today, the ABMP Neck Summit. Thank you very much for taking the time out of your busy schedule to be part of the webinar today, and I hope you find this webinar subject material very pertinent to your day-to-day experience in the clinic. The topic that we're going to explore today are the three major muscles that could limit cervical rotation. So again, in my experience, these are the three most important muscles commonly, but there could be other possibilities. But once you understand the process, you can implement the same sort of structure in whatever muscles, in whatever avenue you need to explore. So I think this is a wonderful representation of that. A couple of things first before we get into the seminar content, in that, why the neck? Why is it such an important place? I think there are two things, at least, that I want to bring out. Number one, precision neuromuscular therapy, not approximate neuromuscular therapy. When someone comes in and says, as you'll see a little bit later, I have a restriction in turning to the left, and when I do that, I feel it on the left, not the right, that means something. Our job is to know what that means and how to translate that into something that we can execute as a strategy for treatment. That's a very tight target. It is, and very tight targets need very targeted approaches. It seems rather obvious. You can't take a very specific outcome and approach it in a very general way. Sometimes that works, but sometimes, a blind squirrel finds a nut once in a while, but that's not exactly a strategy that you want to employ. And the other thing is that it's about efficiency. We want to target only the muscles that are involved, and we want to know what we're doing, why we're doing it, and what we expect the intended outcome to be. So all that's true all over the body, but in the neck, all that happens in a really small geographic space, which makes it just amazing, where little things can have a massive impact. And so it's rather disproportional. Move over 5 millimeters and you're just in the wrong place, and the outcomes won't be what you want. So it's a wonderful representation throughout the whole body, and I think using this in the neck, I think you're going to see how these principles translate anywhere. Secondly, why the neck? Part of it is bidirectionality. It's a very interesting principle. If, for instance, your hips aren't level, will that end up affecting your neck? Absolutely. Because up the chain, the neck is the most mobile segment of the body. So any discrepancies, any problems from below, ultimately, because the neck has the capability to do it, it's the one that has to adapt to make it happen. So from below up, the neck actually suffers. That's one. But the other direction is also true. So if you have a problem in the neck, it, in a way, disproportionately, and unlike any other part of the body, has an influence from below. There are several aspects to that I think are very interesting. Number one, would you agree if I said the upper cervical vertebra have the ability to create a headache? You would say the answer is yes. And you'd be right. And there's lots of research to bear this out. But here's what's interesting. Pain in the head can actually make the neck sensitive. So the direction is head to neck, not neck to head. So here's what's interesting. If you believe that all headaches come from the neck and you start treating this person's neck, you're going to find sensitivity and more sensitivity and more sensitivity, which in your mind will confirm, oh, yep, the neck's involved. What you don't realize, it's actually coming the other direction. The headache pain or a problem in the temporomandibular joint can actually make the neck sensitive, and treating the neck from now till next November won't make it better because the direction is the other way. So that's part of what makes it fascinating is it the cause or is it the effect? It gets really complicated really, really fast. So what I want to give you are ways to navigate through those waters, but I think it's another reason why the neck is so, so important. If you have neck issues, you are 3 times more likely to have lower back pain. If in one research study that I just loved, they took someone with an issue in the neck, an issue in, I think it was like extensor digitorum or something of the wrist, infraspinatus, I think, some shoulder muscle, and also tibialis anterior. Here's what's interesting. Deactivate the tibialis anterior, and what gets better is, who knew, the tibialis anterior. Everything else stayed the same. Deactivate the infraspinatus tenderness, the infraspinatus gets better, everything else stays the same. Here's what's fascinating. Deactivate a muscle that affects the neck, all of the other points, the wrist, the shoulder, the tibialis anterior, they all get better. Whoa, it's like the neck is a master volume switch. Turn that down and everything else below it also starts to quiet. The other direction wasn't true. That's fascinating. So it makes the neck even more important. So, and why rotation? Because clinically rotation is the thing that shows up more than anything else. If you have restricted neck extension, and many people do, and they have no idea they do, because there are ways you can compensate for neck extension. Compensating for neck rotation, except for backup cameras, not easy. You know, when you're backing your car out of the driveway, if you're not great with the mirrors and you feel like you need to turn your head, if you can't turn your head, you're just dangerous, right? And you know it. So, and there are all sorts of things in life where turning the head shows up where other ranges of motion, flexion, extension, lateral flexion, people can have big time lateral flexion restrictions and never know it because it's not something that's as incorporated into their daily life. That's why rotational issues are so important and the thing that you're going to present with. So if you knew how to do one thing in terms of the neck issue, increasing rotation is a great choice. And hey, guess what? That's exactly what we're going to do today. So in the first phase, we're going to do this in a couple different phases. The first phase, we're going to go over some measurement issues. Just like any GPS system, to get where you want to go, you need to know where you are so you can plot a course to the intended destination. If you don't know where you are, you don't know where to go. You don't know how to get there. So we're going to go through some measurement, some range of motion measurement. We're also going to look at the biomechanics of the neck and how that moves. It's not exactly how most people think. It isn't a pure rotational thing for C3 and below. It's actually the more like an arcing the way an airplane might bank and make a turn. So we're going to look at the biomechanics of the kinematics of neck movement. And then we're going to look at the possibilities of facet issues. Then we'll do a representation of what the muscles look like using a TheraBand, the semispinalis, the splenius, and then the obliquus. And then we'll go to the table and show you multiple ways that you can approach these muscles. Now, again, when we do this, I'm going to show you multiple ways to do that. It doesn't mean you have to do all of them. It's just that more choices are a good thing. Because if the person can't do it in one way or you, for whatever, it doesn't work for you, that's fine. You have options. The more options you have, you get to be an artist and you get to paint that palette in the way that is best for your client instead of the way somebody showed you how to do it. It's about being an artist, not a technician. It's about being a chef, not a cook. So here we go, and we'll start first with measuring range of motion. In order to assess cervical rotation, you could either have the client in the seated position or in the supine position on the table. There are advantages to both. I think in some ways the seated position is the most accurate, and that is more functional position. It's the one that they're going to be in life doing that. Most people complain that their rotation is restricted when they lie down. It's really when they're living their life and being in gravity anyway. So I think it's more accurate, it's easier to see, but on the other hand, the convenience of the table is that we're going to be treating different muscles, and then you can get a quick read right away whether it's making a difference or not. So convenience, accuracy, the only thing is whatever way you started in the beginning, you have to continue with that because you're trying to do apples to apples here to make sure that you are getting the change that you hoped you did. Now, for me, what I do is I stand behind the person, and when they've described their restriction, what you're looking at is if you think of a part going straight as though it were straight in the center of their head, going through the nose, right? So Eric, I'm going to ask you to turn to the left, okay? At whatever level is comfortable for you. So go ahead and turn your head to the left, right? And then what I'm looking at is that angle of a center part through the hair and the nose relative to the starting angle. And you can do that visually, or you can use a goniometer. And if you're using a goniometer, the stationary arm, the one without the writing, where that part started, where the nose was, and then cut through again, that center part in the hair and right through the nose. So when we look at Eric, Eric, is that an accurate measurement for you? Is that where you are? Yeah. So Eric is at about 36, 37 degrees of rotation to the left. Okay, so Eric will go back to the starting position, and if you would, now turn to the right, at whatever level is comfortable for you. Okay, so it definitely looks a little farther to the right. We'll see if that's true. So, yeah, kind of. So Eric is now at 55 degrees going to the right. So 55 to the right. So there's quite a difference left to right for him. So two things about this. One of which is you're asking them to go to whatever level is comfortable for them. Some people will say, oh, I get to a certain place, but then I can really push it and I can go farther. That's not very accurate because when they push it, you're assuming that every time they push it, they can push it equally, and that's one heck of an assumption. So really the first inkling of, boy, it's a little difficult here, that's probably the most reproducible position that you want to go for. So the second thing is, Eric, can we start over again? And you're good. Look straight ahead, and I'm going to have you turn to the left. Okay? Turn to the left one more time at whatever level is comfortable. Okay? So Eric is now turning a little bit farther than he was before. So I lied a little bit about that thing. Because what I want to do is I want to take probably 2 to 3 measurements. So I'll talk to them for a little bit and say, I can't remember the number. Let's do it again. And what happens is if every time Eric does it, he's a little bit better and a little bit better, I really like our chances at making a difference because it's lengthening, and each time he does it, it's getting a little bit better. This is a very good thing. It tells me that the problem is probably muscular, and my chances of making a difference are really, really good. If Eric is at 40 degrees when we measure initially, and then 36, and then the next measurement is 30, number one, stop measuring, and number two, there's an active problem there that every time Eric is making that motion, it's activating it, it's irritating it, and so the dragon is home and he's not happy. So, the way to find a dragon is not by kicking around because you're probably going to get burned. Know that when range decreases, there's an active problem. Go very slowly, very carefully, because something is quite aggravated in there. And if you're not careful, if you're too aggressive, it can blow up in your face, and not a good idea. So the other thing that's important during the range is we want to know when Eric is turning his head. For instance, Eric, when you turn to the left, where do you feel that? Do you feel it on the left or do you feel it on the right?
I feel it on the left.
Yes.
Kind of down the yeah.
Kind of down the shoulder?
Yeah, down the, yeah.
Okay, great. So that's a very important distinction because Eric, there are really two possibilities. One of which is Eric turns to the left and feels it on the left, as he said, and also kind of feels it going down the thoracic spine. That's one. The second possibility is that as Eric turns to the left, he's feeling it on the opposite side, on the right side. Those things tell us two very different things. They point to very different muscles, and so we would approach them totally differently, and it all is dependent on what the client says. So one thing is, clients need to understand that their feedback is really important. We need to know, where do you feel this? What's the quality of that? Where do you feel it? Because that changes how I will respond. And that's kind of part of the beauty of the work, is that when someone has a restriction, there's no routine that we do. It's all based on what their needs are, and everyone who comes in is going to have some different reason for the same symptom. So that's part of the beauty of the work, and part of the artistry of it is that it's a blank canvas, and everything that the client says, everything that they do, tell you how you're going to paint that canvas to create the painting you want to paint. And that's the artistry part of it. But you can't get there without the science part of it, which is knowing when he says this, what does that absolutely mean? So there are two possibilities with this. First, in Eric's case, as he turns to the left, he feels it on the left. Eric, does it make a difference? Does it get worse or better with you if I do that motion? Worse. Okay. You want to think about that more?
No.
Okay. All right. Just checking. Okay. So now that's really interesting, because if, for instance, it's a muscle, I just turned Eric's head in to the left and also did a little side bending and a little extension. That should actually shorten a muscle, but he's actually saying it's worse. That tells me something, that the problem with Eric in one way may not be as muscular as you might think. So, and to really understand that, what we need to go over now are the biomechanics of rotation and how they're combined with lateral flexion. And the biomechanics of rotation are really interesting, and let's do that now. Okay, so one little note about a possible facet irritation is this. Here are the biomechanics of cervical rotation. I think a lot of people think that rotation happens in a straight plane movement like this. That may be true at C1, but that's not really true for the rest of the cervical spine. The way it happens is more the way an airplane actually banks and makes a turn, which I think in aeronautics it's pitch, roll, and yaw. And I don't even know what those mean, but anyway, yeah. But I know it's different motions. It's lateral flexion, rotation, and I can't think of the other one. But here's what it looks like in the neck. So here's one of the facet joints. Here's another facet joint. So what happens in cervical rotation is when Eric is turning to the left, right, it's a movement that looks like this. So see how this facet is actually compressing, and this one on the opposite side is opening up. And then you have one above me, and so far they're all stacked together. So a movement that is rotational actually compresses on the left side and really opens up on the right side, just like an airplane would bank going off to the left. Well, as you can see then, if you're compressing this way, if there's any kind of irritation or inflammation in those joints themselves, that's going to be a problem. So this is really important, because if Eric as a client, boy, every time I do this, I feel it, and I'm getting it on this side, I need to really loosen my neck up. What he's going to do is he's going to keep going to the side, trying to loosen it up in his mind. That's going to make it far worse, because every time he goes to the left, he's going to be smashing that joint and creating more inflammation. And he's going to be someone who says, boy, stretching is terrible. And, again, as a therapist, are doing things that are kind of stretching this, and you keep turning him to the left, you are also going to irritate that joint. So the treatment for this would be wildly different than if it were a muscular restriction. Now again, here's how we knew this. Turn the head to the left. If I side bend him, think what that's doing to all the muscles on this side. It's actually shortening them. And then if I do a little extension, since these muscles we're looking at are in the back, I shorten them further. Instead of giving him relief, it actually created more discomfort. Now I know what I want to do with Eric is actually open up the left side, going to the opposite side, going to his right side. You could actually do that in a seated position, which we'll do later. But for Eric, this should feel nothing but good. What you try to do is don't be too hyper precise about where you put your finger, otherwise the muscle stuff could be a little tender, or the inflammation around the joint will spread to the muscles, making you think, oh, it's muscular restriction. It's actually just a spread from the joint itself. So just kind of soften your hands and take them to the opposite side. What Eric should feel when you do this is nothing but, God, it just feels good. Okay? And sometimes unsatisfyingly so, because what people have in their heads is that I need to recreate the symptom and just keep going against that wall until I break through and open it up. And that's a disastrous strategy with this kind of so in this, you're just going to feel a nice stretch, but it's not going to recreate the presenting symptom, and that is by design. And you probably need to do this fairly often. This is not something where you'd see somebody and then see them again 2 weeks later. You need to do this far more frequently than that. So high frequency, very short duration. But I would say 3 sessions, 3 short sessions certainly within 2 weeks, maybe even shorter than that, shorter time frame than that, would really make an enormous, enormous difference. So that is what's happening with a possible facet irritation. So if Eric were lying on the table, again, when he turns to the left, he'd feel it on the left. I can actually add a little lateral flexion on the table, and then boom, I can take him right into rotation to the opposite side. And I'll show you what that looks like when we do stuff on the table. One of the other things we want to look at are what are the muscles involved and what are their dynamics in this process, and that's the next thing we'll look at. Okay, so using a little TheraBand, what I want to do is represent really the mechanics of cervical rotation, and especially 2 muscles to begin with, and that is the splenius cervicis and also the semispinalis cervicis. Now, they work for 2 different teams. They play for different teams. I should have gotten jerseys, actually, for them. One team is called the contralateral rotators, and one team is called the ipsilateral rotators. I know it doesn't really roll off your tongue. The cheerleaders, yeah, I mean, you can't even get the name on the jersey. But anyway, so in the ipsilateral rotation department, so that is the splenius cervicis. So the TheraBand that I have represents that muscle. So Eric is now a vertebra, good looking vertebra. And so this, all right. So this is the spinous process. This is the transverse process. So the splenius goes from the posterior tubercle of the transverse, angling down. Its lower attachments are at the spinous process. So when that muscle contracts, what it does is it rotates Eric this way. Notice how on the opposite side it's going up, it's pulling this down. It's in a perfect position to do ipsilateral, same side rotation. So this is the right side, so the right splenius creates right rotation. Now, conversely, we have this locked in. Think about what happens when poor Eric is trying to turn to the left and the right splenius says, don't want to go. So now Eric cannot turn to the left, but where will he feel it? He will feel it on the right side because the splenius is not thrilled about lengthening, and that's where he's going to experience discomfort. So restriction to the left, discomfort on the right. That means it's an ipsilateral rotator that is not lengthening. So part of the tricky thing with this is knowing here's what it does, right, which is same side rotation. So if it does same side rotation, it will limit opposite side rotation. Okay. Everybody struggles with this. You just have to somehow go over it again and press save in your brain. It takes a while to lock it in. Now, playing for the other team, the contralateral rotators, we have the semispinalis cervicis. And the semispinalis cervicis, we'll do the same kind of position, Eric, except now, I'm going to staple this to your, no, maybe not. So if I put this, so this is now the spinous process, especially at C2, so it goes from the midline, from the spinous, to the transverse process down here. Now when that muscle contracts, it's going to actually pull him this way. So this is the left side, but it's turning him to the right, which is a contralateral rotation. So if you just think about the angle, notice the angle starts midline, goes lateral, semispinalis on the left will turn Eric to the right. Now, this is nice, but no muscle does anything by itself. The weird thing is the splenius over here, right? The right splenius, the left semispinalis, if they both contract, both of them turn Eric's head to the right. See, so they're working in some ways they're opposite, but they're working for the same goal, which is to turn Eric to the right. So contralateral rotator, ipsilateral rotator. So now, if, back to the semispinalis, here's the semispinalis. When it contracts, it's going to turn Eric to the opposite side. Well, guess what happens if Eric wants to go to the left? This guy's pulling and it's not going to let him. But where is Eric going to be feeling the symptoms now? On the left side when he has restricted left rotation. Very important. What they say matters, but we have to have the functional anatomical understanding of how to turn what they say into a very clear treatment protocol to make a difference. And again, you'll know you make a difference when you stand above them, you repeat what we started in the beginning, and you see big time changes after what seems like not a lot of work. But just like the difference between poetry and prose, it's not the amount of words, it's not the amount of work that you do, it's how clear and how precise that work is. That's what gets you what you want. It's not effort, it's clarity. So to actually translate what we saw on with Eric in terms of rotation and a possible facet irritation, I just want to show in the spine again, here are the facets angled this way. So what we want to do is use lateral flexion and also rotation to the opposite side of the problem. So we're going to be rotating Eric's head to the right and also laterally flex him to the right. Both of those things will open up the facets on the left side, which is what he needs. And there are several different ways to do this. In precision neuromuscular stuff, our treatment protocols are really flexible. The key is not having some sort of precise way of doing things. The key is to having a very clear idea of what is it that you're trying to do. When you understand the question, you can formulate an answer in response to that question. So don't get married to the answer, get married to the right question. The question is, how can we open up the joints on this side to give him some relief? And that is probably somewhat mechanical, somewhat neurological, and also probably some tissue fluid stuff. Because as we're opening this up, gapping it and closing it, we're probably on all three of those levels doing something very helpful for this. And again, I assume that to be true because I've done this many times with people, and their symptoms over 3 days have disappeared, and it's not common for them to come back without some extenuating circumstances. So, all right, here we go. So I'm going to put this away for 1 second. Actually, I'll just do that, and you can scoot over that way. Okay, so now here's Eric. Here's the left side. Do you know, Eric, at what level you were mostly feeling that? Do you think you could point to it?
Oh, yeah, I think so. I mean, it's
Oh, you felt it much lower.
yeah, quite a bit lower.
Okay,
But
all
it
right.
does, yeah,
But
kind
you're
of affect.
also here.
Yeah.
Okay. So I think what's happening is that effect is actually going down the whole muscle. And the muscle that is stretched, if you remember when Eric goes to the left, is the semispinalis. So I think what's happening is the whole semispinalis is being affected. So we can address that as well. Now, just for the facet joints in the cervical area, here's what we're going to do. I'm going to take Eric, and using my hand this way, I'm just going to gently, and using a fair amount of surface area, don't be too over-focused with your fingers or with your hand, because I want to create a gentle lateral flexion, kind of exactly, I'm pushing exactly opposite where I think his restriction is. So if I push from the right, I'm opening the facets on the left. Is that okay with you?
Yeah, I'm starting to feel the soreness, but it doesn't feel like the pinch when you do it to the
Right.
other side.
So he's actually feeling something opposite where I'm pushing, and that's a good thing because now we're stretching and opening that. We're probably on target. Now what I can do is I can actually rotate him to the right side while I'm creating lateral flexion to the right. That's one way of doing this, sort of step one. It's in the cervical vertebra, and there are several other examples of this throughout the body. It's called combined motions. You cannot rotate without creating lateral flexion. The cool thing about that is that you can use lateral flexion to affect rotation. And that's what we're doing here. So the movement I'm doing really is mostly lateral flexion, some rotation. Or you could add to that, or trade for door number 2, which is that as I do this pressure on this side, I can take my hand, my left hand, and pull this way, and I'm just really anchoring all around the facet on the left side and pulling it up and forward, which is to turn Eric to the right. Is that okay when I do that? Yeah. Is that painful at all?
Only when going backward.
Yeah. So what Eric is saying, it's only painful on the return side, which again kind of supports that whole idea. So again, you have a couple ways to do that. One of which is, if Eric feels that, I may not do as much of a return. If I do this, do you feel that?
Yeah.
Do you still feel the same thing?
Yeah, I feel the stretch. Yeah.
You feel the stretch? Do you feel the pain when I let go, or no?
No, not when going
Okay.
back. That's a good
Yeah.
range.
So now what I'm doing is, what Eric said is, because I'm operating in a small range, he's not feeling that discomfort, so I'm going to stay within that range. Somebody else, I might actually come all the way back to midline and repeat the same motion again and get those bigger motions, which to them is going to feel really, really wonderful. It's all about creating an effect that in a way you would intend. And if it's not what you intend, your brain has to say, what would explain that? And how can I turn that into something useful in terms of treatment? That is always the key. Turning whatever is presented into something that you will then execute as a treatment strategy. You okay with that?
Yeah.
Okay. So another way to do this, if you want to trade for door number 3, is that I can do the same thing really one-handed, because now my finger on this side is guiding that facet forward on the right, and with this hand I have a little more control of the movement of his head at the same time. Hi, Eric.
Hi, your finger just found something.
Yes,
there.
it did, didn't it? Yes. Eric said, ooh, your finger is on something sensitive. Now, again, do I want that? Where I am right now is on the posterior tubercle on the left side. I'm thinking that there's nothing inherently great about being on that right now, so I'm going to soften my pressure to make it a little more diffuse than hyper-specific. if it made sense for me that there was the muscle, which would be the splenius, which was the restriction, maybe I could decide to treat the splenius with a more focused pressure. In all of this, it's really important to understand that there are just all these treatment avenues. You're not going to be right. Certainly, that's not my experience. It's always you perceive, then you intervene. Does the response match what you expected? If it doesn't, change strategies. Perceive, respond. Does it match? If no, change strategies. But that's the artistry part of it, that it is never just you're doing the same thing all the time. You're always changing and adapting. And again, that's part of that inside game that makes the work so rich. And, to a client, they're just thinking, oh, you're just working with my neck, which is about like me watching someone play golf, which I think is just short of narcolepsy, when they're standing over something and putting, and it's because they're making calculations I don't even know to think about. It's much more fun for them than it is for the observer. So, sorry for all the golfers out there. So this is the same sort of thing. So what I'm hoping for is a little bit of a change in terms of Eric's range. Now, this is the other thing. After doing this, I would need to have Eric sit up, because that's how we measured it initially. Is it reasonable to expect that Eric would have gotten full range? It is not reasonable if the problem really is some sort of irritation at the facet itself. That irritation is not just going to let go. That's a process that is going to take hours, actually, if not probably 72 hours to fully finish. So what I would expect from Eric is that when he sits up, we'll see a change in range, that his range will have improved. However, he's still going to feel that same thing when he turns, but his range should improve, and the severity of that kind of pinch that he feels should decrease. It's typical somewhere between 40 and 60%. If that happens, we are absolutely on the right track. And I can't stand it. We have to do this. I didn't want to do this. But if you could just sit up, we'll try to get this in the camera. And I'll just do it this way. Eric, if you would. Yep, just face this way. Turn to the left, if you would, now. Oh, yeah. Actually, can you hand me the goniometer? Thank you, Jennifer. That guy, yep. Let's just measure that. I'll show you where we are. Okay, Eric, I am ready. Okay, go ahead. Okay. Okay, so that is 60 degrees. No, 59. So, does anybody remember where we started?
It was in the 30s.
30s. Yeah. So whatever it is, it's clearly a lot better.
Yeah.
So 59 degrees.
Yeah.
And your experience was?
It's still there, but yeah, like I can do that.
Yeah, well, that's a little different. Yeah. Mm-hmm. Do that one more time. Yeah. Because now, that is now 65 degrees. Yeah. So now we're moving in the right direction. This is what we hope for. It's completely expected, and if it's expected, it means that my assessment, my model of understanding of what's going on is probably correct. I like the chances for a really good outcome. Cool. Thank you. Okay. For treatment of the splenius cervicis, remember the splenius is a same side ipsilateral rotator. So on the left side, the upper attachments are to C1. Here's the mastoid process, and Jennifer's C1 is right there. Again, notice how far anterior C1 is. Oftentimes when I'm doing trainings, I ask people, where's C1 and transverse, and people will point back here. But the C1 transverse is very, very wide, and in most cases is just underneath the mastoid process. So now, a little known fact about the splenius cervicis, it's actually a family of triplets. You may not know this. So the triplets in the family are the splenius cervicis, the levator, and the middle scalene. Now, when you look at different anatomical texts, what you see is that the splenius and the levator, sometimes you'll see them listed differently. One's posterior, one's anterior. If different texts say different things, that's an important principle because in your person, you actually never know. If you've done cadaver dissection, you know that everyone is really different. So don't memorize a principle like that. What you want to do is put your finger where you think it is based on that typical anatomical understanding, and then have the person contract the muscle. So Jennifer, you're going to turn to the left, this side, the other left. Okay, to this side, that's it. And now I feel the splenius contract. Now, if I'm on the levator mistakenly, not a bad mistake, because they do very, very similar actions in terms of movement of the neck. So they're both ipsilateral rotators. So if I'm wrong, I'm still right. I like this, okay? So this is the transverse process of C1. So the transverse process and posterior tubercle of C2 and C3 are probably a little farther posterior. So against kind of this wall this way. So you want to make sure that your wrist position is like this, angling anterior and rather obliquely. And again, to be sure, if they just did a little bit of contraction, you should feel that muscle pop up right underneath your fingers. So in order to treat it, that's the motion that we're going to be doing. Very small, like superior, inferior motion right against the posterior tubercle. Again, different texts say different things. It's the first 3, it's the first 4. People are different. So give yourself either a margin for error to treat all the way to C4, or every time you feel it contract, treat that. So splenius cervicis. Now, if I wanted to, the other possibility I could do is, as I was doing with Eric earlier, if I place my finger on this side, I could either, what I was doing before is I was actually just treating against the posterior tubercle. That's treating the muscle attachment. If I want, I can actually add a dynamic movement to that, so I can have Jennifer turn away, and I can have it passively or actively. Both are valuable. If she does it, then what you're doing is using reciprocal inhibition to stretch that muscle, because as she contracts the splenius on her right side, you are now causing the one on the left side to let go. This is a good thing. Sometimes people struggle with that, or just kind of getting it right, or they're spacing out and they can't do it. I'll do it passively. And the nice thing about passive movement is the element of control. So I can go in a much smaller arc, I can go back and forth, I can take it farther. I have more control that way, and sometimes that's a better thing, especially if it's a little lit up, because people will try to do too much, and that might actually aggravate it a little bit. They'll try to overstretch it. So, you know, both are possible, both are tools that you can use. So now remember that at C1, that's much wider, you're not going to be able to probably do that with your finger underneath. But C2, C3, C4, you know, C5 for good measure, probably not a bad idea to do it this way. Now, when we get to the idea of actually treating each one of these in terms of its lower attachment, how do you get there? So these muscles in the cervical spine are attaching at posterior tubercle and transverse process, but where they're originating from in the thoracic spine is against the spinous process. So what I'm going to do is I'm going to place my finger under the Jennifer's thoracic spine, and I'm going to be right against the spinous process. It could be anywhere from T6 and up. And as I stretch the muscle from above, the tighter it is, the more likely I am to feel something below. So if you pull from above and it's restricted, you're also going to feel a movement from below. If the muscle, it has full length, each segment is different. If I move up a segment and now when I move from above I feel nothing below, that's actually better. That's ideal. So in order to know which one you want, it's the one that moves the most is the most restricted. It's a little counterintuitive. So I put my finger, I'm reaching underneath her thoracic spine. My middle finger is right against the spinous process. Is that sensitive at all? Mm-mm. Yeah, not sensitive. Not sensitive. Yeah. So unlike Eric, actually, Jennifer is not presenting with a restriction, so which is good. Good for Jennifer, bad for us. But so what I would do is I would start, say, at as low as I could reach comfortably on the thoracic spine, and now I'm going to make that motion. And as I stretch the muscle from above, do I feel movement in my index finger against the spinous process? And then I pick up and move one vertebral segment, rotate again. Compare door number 2 to door number 1. Move again. Compare door number 3. And I just keep moving up segment by segment. Notice that my finger up here, if I pull from below by flexing my finger against the spinous, and I'm flexing my middle finger from above, I'm actually taking the muscle kind of in a double movement. I'm stretching it from below and stretching it from above. Kind of what we call a glide and go. The muscle's going in the same direction from below and from above. You okay with that?
Yeah, that's good.
Yeah. Most people say it just feels wonderful, and that's the whole point. You could, we don't tend to do this often, but I could anchor from below and lock the pressure and then turn from above, and that's more of a stretch. Now remember, these muscles create rotation to the same side, but remember the lateral flexion component. So the more I add lateral flexion and rotation, the more stretch she's going to get. And she's saying yes. So if I anchor the bottom and don't let my lower finger move, add lateral flexion, add rotation, it's much more of a stretch to her. That may be a good thing. There are times when a very direct approach is not the wisest move. So that's, again, part of the artistry thing is you have to decide how direct do you want your treatment to be or how indirect do you want it to be.
Feels good.
Yeah, there's a time for both. So this muscle generally would be the surfaces T6 to T3 generally. Give yourself a margin for error. There's no harm if you're doing this. If you go higher than that, you probably just, you'll get the splenius capitis. Not a problem. Similar functions. The capitis just doesn't have quite the same effect in rotation. Okay. So this is the splenius cervicis. Now, playing for the other team, the contralateral rotators, okay, is the semispinalis cervicis. Now, where the semispinalis cervicis attaches is, remember that thing I was doing with Eric, from above it's actually attaching to the spinous process, and below it's at the transverse process. So now the major attachment and the major player is C2. So what you have to feel is, if you just take your finger, and I'm using my right hand underneath, you could do either, taking my right hand underneath, and I'm going to feel for the first really large bump that I feel, which is the spinous process of C2. So in that spinous process, yeah, let's bring that. So again, when we look at this guy like this, here is the spinous process of C2. C1 really doesn't, as a posterior arch, doesn't really have the big spinous process. So where you want to be is on the lateral aspect, and lateral and inferior. That's actually important. So Where you're going to feel this is you feel the big bump, spinous process C2. Now I'm going to take my finger and I'm going to be on the inferior lateral aspect of it, because that's the direction of this muscle. It's going from there down to the transverse. Now, what does it do? It does same side rotation, limits, it does opposite contralateral rotation, limits same side rotation. So what I'm going to do is actually put my finger against the spinous process, and what's different about this now is I'll do a little lateral flexion, but I'm going to rotate Jennifer to the same side, so I'm turning her to the left as I'm treating the left semispinalis. It does contralateral rotation, so I'm turning her ipsilaterally, and I have my finger right against the spinous process. You okay with that?
Yeah.
Yeah. Is it a little sensitive at all, or no?
Not really.
Not really.
Not
Good.
too bad.
Good. Okay. So now I'll move down one segment. Do the same thing. I already have her in a little lateral flexion. Now I just turn her into same side rotation. And I'll just walk right down her cervical spine right against the transverse. And each segment can operate individually. So you could have the segment at C3 be really sensitive, C4 nothing, C5 sensitive, C6 nothing. So you have to treat and explore each one individually. So, and remember, the twin to this in many ways is the the sternocleidomastoid, because it also is a contralateral rotator, and you can see that when I'm turning her this way, I'm also affecting the sternocleidomastoid. So they're on the same team, okay? So as I do this motion against the spinous process, from below, where is this going? It's going from the spinous above to the transverse processes in the thoracic spine. So now what I'm going to do is I'm going to the same thing that we did, but my lower finger, my middle finger is going to come up against the transverse process in her thoracic spine. So I feel the spinous. There's the longissimus section. I move just lateral to longissimus, and what feels like a little nub. Hi. Welcome to your transverse process. Okay. So now I'm right on that transverse process, and now as I turn her to the left, what do I feel in my inferior hand? The more movement I feel, the more restricted the muscle. If I don't feel any movement at all, then that's actually a good thing. Jennifer, I have a question.
Yes.
Door number 1, door number 2, which is more sensitive?
They were about the same.
About the same.
Maybe the first one.
Okay. And then this one? About the same?
Mm-hmm.
Okay.
A little less.
A little less. And this?
Less.
Yeah. So that really matches almost what I was feeling. I felt a little more in door number 2 movement-wise. They were pretty close. She gave the slight edge to door number 1. So, and as we went up in the upper thoracics, I felt really nothing. So I'm going to go right back to where we were. I'm probably like T5 area here, somewhere in that area. And for me, and for you, does that feel more sensitive than above?
Yes.
Yeah. So that's where we want to be. So the movement is lateral flexion to the right, same side rotation, which is rotation to the left. Now it's a double whammy. If I wanted, just showing off, I could do that same thing of taking my middle finger on my right hand, hooking underneath and on this side of the spinous process, and I could do both things at once. So now I'm treating both ends of the muscle at the same time, which is a fabulous way to do this. You okay with that?
Mm-hmm.
Yeah. Really, really great way to do this. All right. So that is the semispinalis cervicis. Now, the third player in our little trio here is the obliquus capitis inferior. Now, you'll see in one of the slides that that obliquus goes from the transverse process of C1 over to the spinous process of C2. And I am going to show that in the camera as well. So that guy goes from spinous process to transverse process. And remember that C1 is the one that can actually pivot in a pure rotation. So if this is stable and this is movable, this is the right side. If I move C1 towards C2, which is what will happen, do you see how I'm going to get same side rotation? Therefore, that muscle must lengthen when I rotate to the opposite side. So it plays for the ipsilateral team, okay? And the muscle's angling just like that. In terms of mechanical advantage, this little guy has amazing capacity to influence rotation. Ideally, you should have optimally 90 degrees of rotation, which honestly few people have. What is functional? Functional is probably in the 70 degree, 60 some, if you can do that, you probably don't notice a restriction. But in the 90 degree ideal rotation, half of it, 45 degrees, can come just from this segment at C1. That is amazing. So all the big muscles that affect neck rotation, this goofy little guy right here can affect half of the range that you need. That's a lot of power for a little guy. So this muscle is really important, and I don't know who the marketing director is for this muscle, but they definitely should be fired because it just doesn't get much press. Here's the thing. This muscle is here. Underneath it, coming underneath it and going back up, is the greater occipital nerve. You must be very careful about this. People who have occipital nerve irritation will present with a headache here, and the last thing in the world you want to be doing is digging around in here, because you're going to give them a headache that's going to last for a long time. I mean a long time. Really not a good thing. And the symptoms that they will present, they will tell you that, for instance, they cannot sleep on their back. Anything that puts pressure in this area gives them a headache. If they say this, the antenna go up, thinking about greater occipital nerve problems, and again, you're in a no digging zone here. Now, what you can do, because the nerve comes around this muscle, is you'd like to affect it without touching it. So you could treat against the spinous process, you could treat against the transverse process, but you cannot touch the belly of the muscle. So these people, even a headband, for instance, drives them crazy. So you must be very careful about this. Also, it's worth noting that the artery is right here as well. So this is an area that you just don't use a lot of pressure and dig around in here, because you may not like what you find, and neither will the client. So let's be much more precise about this. So here's what we're going to do. For instance, now we were there before. Remember, at the C2 spinous. Now I'm going to be at the C2 spinous, but not on the inferior aspect, but on the superior aspect. So, you okay with that?
Mm-hmm.
Yep. So I'm on the superior aspect of C2 spinous and treating right against the bone. Now, I'm going to use my left hand to do this. You're okay? Mm-hmm. Find the mastoid process, go below that. Ooh. There is C1, transverse. Now I can treat against the C1 transverse. I'd use probably a couple fingers like this. And now I'm treating both ends of the muscle. Alternate spinous, then transverse. If I was sure that there was no greater occipital nerve involvement, no history of headaches, any pressure behind the back of the head giving them a headache, that kind of thing, now what I can do is take my middle finger and I'm going to block C2 from moving. Because when that muscle is tight, when Jennifer turns to the right, what happens is C2 moves towards C1. Very clever. The muscle says, oh, I feel a stretch. How can I get, what do I need to do? Oh, if I just actually move C2 closer to C1, I can take the pressure off. But we say, au contraire, right? We're not going to let you do that. So I'm going to block C2 from moving while I take C1 towards me. So my finger on her C2 spinous is holding the vertebra from moving, and now I'm very specifically stretching only that muscle, really to the exclusion of other muscles. Hyper precise. And that's what it should feel like to the client. Like, you know, it's a very different model than just kind of gliding up the neck or working in a whole area. The person can feel that specificity. And that, as you all know from being on the table, is a really wonderful feeling to know that everything you're doing is targeted exactly to one area. Now again, if I wanted, I could block it, stretch it, or I could take my finger and lay it across the whole area like that and pull. So now I'm pulling really with my finger on my left hand, finger on the right hand, just kind of gliding everything toward each other this way. Nice way to do that. Kind of gets the whole area all at once. And in this way, I'm shifting back and forth. So now I'm doing this motion, shifting over the muscle. So as long as there's no neural involvement, not a bad thing to do. So this muscle, again, is an ipsilateral rotator, will limit rotation to the opposite side. Very, very powerful player. So, so what we've covered are the three major muscles, and again, these are just muscles in my experience that are the common players with cervical rotational restriction, and they are the splenius cervicis, semispinalis cervicis, and the obliquus capitis inferior. Good places to start. Again, if you do the treatment in the way that I've showed you and you don't get the results, it's not those three. So then think, well, who are other ipsilateral rotators? Who are other contralateral rotators? Is it a facet issue? Should I be looking at something like that? That's part of the art and the science of what this work is all about. So thank you very much for taking the time to watch this webinar. I hope that you find things that are really useful, things that you can employ in your clinic tomorrow. I mean, that's what it's all about. It's about taking what you see and turning it into something useful that you can use to make a difference in the lives of people who grace your treatment table. So if you want more information, then you can contact me. Emails to our website will go right to me. And the website is NMT, like Nancy Mark Tom, Midwest.com. NMTMidwest.com. If you just go to the Contact Us button, those emails will come right to me. I'm happy to answer questions. There are also several YouTube videos, those sorts of things that you can use to have further information. And we're doing around 100 seminars a year across the country. So hope to see you at one of the seminars, and I look forward to meeting you. Thank you so much for the great work that you do. You make a difference, and the world needs what you do.
Thank you, Doug. For more information about Doug's products and his workshops, visit his website.
Hi, I'm Ann Williams. I'm ABMP's Director of Education. I'm here in Oklahoma City for Eric Dalton's Myoskeletal Alignment Technique Workshop. I'm going to bring Eric back with me to the ABMP home office in Colorado because on October 10th, we're going to bring his work live in an online workshop to our ABMP members. We've partnered with Eric exclusively to bring our members this unique content. He's going to show you his favorite techniques and his amazing approach to the human body. Join us live online October 10th.
So from below up, the neck actually suffers. That's one. But the other direction is also true. So if you have a problem in the neck, it in a way disproportionately and unlike any other part of the body has an influence from below. There are several aspects to that I think are very interesting. Number one, would you agree if I said the upper cervical vertebra have the ability to create a headache? You would say the answer is yes, and you'd be right. And there's lots of research to bear this out. But here's what's interesting. Pain in the head can actually make the neck sensitive. So the direction is head to neck, not neck to head. So here's what's interesting. If you believe that all headaches come from the neck and you start treating this person's neck, you're going to find sensitivity and more sensitivity and more sensitivity, which in your mind will confirm, oh, yep, the neck's involved. What you don't realize, it's actually coming the other direction. The headache pain or a problem in the temporomandibular joint can actually make the neck sensitive, and treating the neck from now till next November won't make it better because the direction is the other way. So that's part of what makes it fascinating is it the cause or is it the effect? It gets really complicated really, really fast. So what I want to give you are ways to navigate through those waters, but I think it's another reason why the neck is so, so important. If you have neck issues, you are 3 times more likely to have lower back pain. If in one research study that I just loved, they took someone with an issue in the neck, an issue in, I think it was like extensor digitorum or something of the wrist, infraspinatus, I think, some shoulder muscle, and also tibialis anterior. Here's what's interesting. Deactivate the tibialis anterior, and what gets better is, who knew, the precision neuromuscular therapy, not approximate neuromuscular therapy. When someone comes in and says, as you'll see a little bit later, I have a restriction in turning to the left, and when I do that, I feel it on the left, not the right. That means something. Our job is to know what that means and how to translate that into something that we can execute as a strategy for treatment. That's a very tight target. It is, and very tight targets need very targeted approaches. It seems rather obvious. You can't take a very specific outcome and approach it in a very general way. Sometimes that works, but sometimes, a blind squirrel finds a nut once in a while, but that's not exactly a strategy that you want to employ. And the other thing is that it's about efficiency. We want to target only the muscles that are involved, and we want to know what we're doing, why we're doing it, and what we expect the intended outcome to be. So all that's true all over the body, but in the neck, all that happens in a really small geographic space, which makes it just amazing, where little things can have a massive impact. And so it's rather disproportional. Move over 5 millimeters and you're just in the wrong place, and the outcomes won't be what you want. So it's a wonderful representation throughout the whole body, and I think using this in the neck, I think you're going to see how these principles translate anywhere. Secondly, why the neck? Part of it is bidirectionality. It's a very interesting principle. If, for instance, your hips aren't level, will that end up affecting your neck? Absolutely. Because up the chain, the neck is the most mobile segment of the body. So any discrepancies, any problems from below, ultimately, because the neck has the capability to do it, it's the one that has to adapt to make it happen.
Hi, I'm Jed Henneberry, Director of Marketing and Member Relations for ABMP. I hope you're enjoying the ABMP Head and Neck Summit, and I'm excited to introduce our next presenter.
Tibialis anterior. Everything else stayed the same. Deactivate the infraspinatus tenderness, the infraspinatus gets better, everything else stays the same. Here's what's fascinating. Deactivate a muscle that affects the neck, all of the other points, the wrist, the shoulder, the tibialis anterior, they all get better. Whoa, it's like the neck is a master volume switch. Turn that down and everything else below it also starts to quiet. The other direction wasn't true. That's fascinating. So it makes the neck even more important. So, and why rotation? Because clinically rotation is the thing that shows up more than anything else. If you have restricted neck extension, and many people do, and they have no idea they do, because there are ways you can compensate for neck extension. Compensating for neck rotation, except for backup cameras, not easy. You know, when you're backing your car out of the driveway, if you're not great with the mirrors and you feel like you need to turn your head, if you can't turn your head, you're just dangerous, right? And you know it. So, and there are all sorts of things in life where turning the head shows up where other ranges of motion, flexion, extension, lateral flexion, people can have big time lateral flexion restrictions and never know it because it's not something that's as incorporated into their daily life. That's why rotational issues are so important and the thing that you're going to present with. So if you knew how to do one thing in terms of the neck issue, increasing rotation is a great choice. And hey, guess what? That's exactly what we're going to do today. So in the first phase, we're going to do this in a couple different phases. The first phase, we're going to go over some measurement issues. Just like any GPS system, to get where you want to go, you need to know where you are so you can plot a course to the intended destination. If you don't know where you are, you don't know where to go. You don't know how to get there. So we're going to go through some measurement, some range of motion.
Douglas Nelson. Doug started practicing in 1977, and he still maintains an active practice today. As president of Bodywork Associates, he teaches 100 trainings or so annually in precision neuromuscular therapy. He's a consultant for the NBA and the NFL. He's just a really, really amazing guy. I had the pleasure of reading Doug's columns in Massage and Bodywork magazine for many years as an editor, and I was always really impressed by how his clients would come in with problems and they'd leave with solutions. And I think he's going to do the same for you today in this presentation. He's going to talk about the big three muscles that could limit cervical rotation. He's going to show you assessment methods, explain specific anatomy and function, and then demonstrate some treatment options and hands-on work that you can use in your practice. I hope you're enjoying the ABMP Head and Neck Summit, and I know you'll enjoy this next presentation from Douglas Nelson.
Hi everyone, this is Doug Nelson, and I'm really excited to be part of this webinar today, the ABMP Neck Summit. Thank you very much for taking the time out of your busy schedule to be part of the webinar today, and I hope you find this webinar subject material very pertinent to your day-to-day experience in the clinic. The topic that we're going to explore today are the three major muscles that could limit cervical rotation. So again, in my experience, these are the three most important muscles commonly, but there could be other possibilities. But once you understand the process, you can implement the same sort of structure in whatever muscles, in whatever avenue you need to explore. So I think this is a wonderful representation of that. A couple of things first before we get into the seminar content, in that, why the neck? Why is it such an important place? I think there are two things, at least, that I want to bring out. Number one,